I'm Ruben Mesa. I'm the lead for Advocate Health for the Cancer National Service Line, as well as the executive director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. The unmet needs for ET remain significant in the U.S. and internationally. Currently, this is a group of patients in the United States that we estimate to be about 150 to 200,000 patients. But we really only have one approved therapy, anagrelide, and it's a therapy that has limitations. So hydroxyurea and anagrelide have primarily been the approved therapies that have been used. The clinical trial SURPASS-ET was a randomized phase 3 trial between rope-regulated interferon alpha-2b and anagrelide in the second-line setting. And patients were eligible by being high risk as well as having failed hydroxyurea previously due to resistance or intolerance. What we observed was superiority of rope-regulated interferon at both 9 and 12 months, with a primary endpoint, which was a modified European LeukemiaNet response, which is a bit of a composite between control of blood counts, absence of vascular events, and improvement or no progression in both spleen and symptoms. And there was statistical superiority both in 9 and 12 months for each of those, heavily favoring the rope-regulated interferon alpha-2b arm. Rope-regulated interferon alpha-2b is a therapy that's already approved in the disease polycythemia vera, that in many ways is a cousin to essential thrombocythemia. Both these groups of patients can have challenges of risk of thrombosis or bleeding. They can have difficult symptoms. They can progress to myelofibrosis. And the goal of both controlling the disease but also avoiding disease progression is important. Part of a surrogate marker of trying to decrease the risk of progression has been around a decrease in the driver mutations, JAK2, V617F for P vera, as well as CALR for those with ET. In P vera, the drug had been approved based on superiority compared to other therapies, such as hydroxyurea, in that frontline setting for improvement of counts as well as improvement in the variant allele frequency of the molecular mutations. So in ET, in addition to that first set of responses, which I mentioned as the primary endpoint, improvement in counts, symptoms, spleen, etc., there was clear differences in terms of improvement in the JAK2 V617F allele burden that makes us hopeful that that will have a significant impact on decreasing the long-term progression of the disease as we follow these patients over time. Similarly, there was a stark difference that favored rope-regulated interferon for the patients with a CALR mutation. That subset of patients was smaller, so it didn't reach statistical significance just because of the number of patients involved. So that overall efficacy, I would say, is count control, lack of vascular events, spleen and symptoms, but also this very important set of molecular findings. Fortunately, the rates overall are low that were seen for cardiovascular events and thrombotic events in the study. That being said, it heavily favored the patients on the rope-regulated interferon alpha arm, where there were 8 events in the anagrelide arm and only 1 event that occurred in the arm with rope-regulated interferon alpha-2b. We think part of that may be linked to the improvement not only in the normalization of the platelet count, but also improvement in the leukocytosis that can be present in these patients as well. So it's a more comprehensive therapy for these individuals. Additionally, there were 3 deaths on the anagrelide arm and 0 deaths on the rope-regulated interferon arm. Over time, I think one longer-term follow-up will be helpful in terms of that progression-free survival that we're hoping to assess. We're taking a deeper dive regarding the presence of additional somatic mutations and other subset analysis based on age and other demographic factors to identify those patients which benefit best from rope-regulated interferon alpha-2b.